يمسيكم بالخير. راح نبلش السيشن الثاني قبل الاستراحة، وطبعا طلبوا من الشباب نحكي لكم عن صلاة الجمعة. راح تكون في قاعة عشتار هون جوا الفندق، حتى انه ما يطلعوا برا الناس، ما في داعي لانه في صلاة معمولة هون بالفندق. Now I will introduce our closest friend, Professor Hassan Shahata. Sometimes I shy to introduce you, Hassan, because you're so famous in Amman, Jordan. Everybody knows you, and you have always been our friend, our support wherever we go, wherever things happen when it comes to obstetrics and gynecology, and on the personal level as well. So thank you for everything you do. Before, just a couple of lines for Dr. Hassan. He is a professor of obstetrics and gynecology, consultant obstetrician and maternal medicine subspecialist, and also the RCOG Senior Vice President for Global Health. His NHS base is at Epsom and St. Helier University Hospitals. He is also the clinical lead for South West London Maternal Medicine Network, creating clinical pathway and safe referral system, ensuring all women with pre, anti, and postnatal complex medical conditions have equal accessibility and care. Hassan has a strong research background with over 100 peer-reviewed publications, including NEJM, Lancet, BMJ. His research interests include recurrent miscarriages, obesity, diabetes, renal disease, and obstetric cholestasis. Hassan, the floor is yours before starting your lecture with about intrahepatic cholestasis and what's new about it. So happy to hear from you.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. Thank you very much, Amir and Khaldun. It's always a pleasure to be here in Jordan. It's actually a very emotional time for me today because this is my final visit to Jordan as a college officer. I will be demitting office on the 12th of December. And I think I took permission from the chairs just to mention something about my relationship with Jordan, because this goes back to over a decade. When I first kind of introduced to Jordan through Amir and Ayman Lusmadi. And since then, the relationship grew and grew. Some of you just started as junior consultants. I was just a consultant. And I think over the years, it's lovely to see everyone what they have achieved here in Jordan, not only for themselves, but also for the care of women's health. It has always been a privilege for me because to come to Jordan, because I always feel that this is like almost like my second country. And I've always been welcomed, felt it's like home, and over the years created amazing relationships and friendships which will last, I am sure, forever. And I'm very grateful over the years for all of you who have supported me when I was the Gulf ambassador, then became the council representative for MENA region, and I always know that I got 100% of the votes from Jordan, and that's always been very, very supportive for me. So, and I think we've done well over the years, because if I look at the care of women and babies here in Jordan, I've always felt very proud, because I've said that the nearest to the British UK system has always been Jordan, and I'm impressed that you have kept the quality over the years. So very grateful. I'm hopefully I will still be invited to come back, and thank you very much for the kind invitation for the organizers. And I'm sorry I've come late. Unfortunately, I had a funeral yesterday. That's why I couldn't come today, yesterday, but grateful to be here. So I'm going to be starting my talk today talking about intrahepatic cholestasis. And when the scientific committee has kindly asked me to speak on this subject, I realized actually there are some kind of controversies about when to deliver and what will be the kind of main issues that people want to come across. So I thought it would be a good update to give. So my aim today is to understand the definition and epidemiology of ICP, review the risk factors, recognize the clinical presentations, and also summarize the risks that happen to the mother and the baby, as well as how do we plan and outline something that is evidence-based, and also to discuss most recent updates. I always teach my students, and I say to them, in order to understand pathology, it's important to understand physiology. Because if you don't know what happens normally in a pregnancy, it is difficult to interpret any investigations or symptoms or signs. So in general, we know in pregnancy, there is a fall in serum albumin. There is a dramatic increase in fibrinogen, as well as very little changes in bilirubin. And therefore, if you see someone with an abnormal liver function test with a high bilirubin, you need to think twice what the reason is. There is a fall in the upper normal ranges of AST and ALT, and we know that in pregnancy, because of the hyperdynamic circulation, women will have a spider nevi in their palms. Postpartum, and this is really important, not just for obstetric cholestasis, but even with patients with preeclampsia and severe preeclampsia with abnormalities in the liver, that you expect the levels of AST and LT and gamma GT to go dramatically up after delivery before they start kind of plateauing after that. So what is intrahepatic cholestasis? It's a very simple definition, but it's an important definition. So it's basically the presence of pruritus, itching, with elevated serum bile acids. That is the definition. We can't diagnose it otherwise. In order to diagnose ICP, you need to have those two factors. Not only that, but it's also to note, because sometimes we have patients who have very high levels and we question the diagnosis. What is really important to say that after delivery, it has resolved. And that will give you that definition. So pruritus, abnormal bile acids, and to resolve after delivery. That's what makes the definition. So what is the incidence? So there is interesting variations. First of all, we know it's higher according to geographical location. I'm not sure what is I tried to look what is the geographical location when it comes to Jordan, what the levels are like. But I know it is very high in places like Finland, Chile, and in Portugal as well during the winter in particular. There is a higher incidence in multiple pregnancies. There is a higher incidence with IVF. There is also more common in patients above the age of 35. If you have a pre-existing gallstones or any family history of liver disease, there is also that slight increase. So this multifactorial issues, which is hormonal, multigenetics, and environmental, do create what we see in our population. So, and it is interesting that some of these patients, despite they move countries, they sometimes move that risk with them. There is definitely genetic predisposition, and my colleague, Professor Catherine Williamson, who has widely published in this field, has done a lot of work when it comes to genetics. And there are particular genetic variants of ABCB4, the ABCB11, and the APTB8B1, as well as the NRYNHR, which are particularly associated, and you see that run in families. So if you have patients with a very high levels during pregnancy, do ask them about their family history, and you'll be surprised that sometimes if she goes and asks her mother or her sister, you'll find that actually they've had similar, although it wasn't diagnosed 50 years ago, but they will remember that they had that itching and dark urine, for example. There are some environmental trigger factors, so deficiency in selenium, viral infection. So I tend to advise my patients with previous OC maybe to take selenium in the next pregnancy. That normally would help. Now, what are these hormonal factors? How they work? Because they actually, if you look at the multiple pregnancy, if you look at IVF, there is an increased disposition. So that these patients will have very sensitive livers to an extra estrogen. That's really the base of it. So if you have multiple pregnancy, you have that situation because of the decrease in the hepatocyte membrane fluidity and a decrease in the sulfation of bile acids. We know some of these patients will give you a history of cyclical itching during their periods, or if they had the oral contraceptive pill. We now know that even progesterone can play a role. As I mentioned, selenium is really important. Infections, if somebody has hepatitis C, that also has been shown to increase that risk. But also we've noticed, and this is a study I did with Catherine Williamson more than 20 years ago, where we found a predisposition in patients with gestational diabetes as well. So what are the clinical features? Obstetric cholestasis usually, historically, traditionally, starts in the third trimester. However, we have seen very rarely patients who start having it early, especially with patients with past history or family history. Now, if it starts early, please do look for other causes before you make that readily kind of diagnosis, because there may be something else. They generally have pruritus, as I've said, mainly in the hands and soles, but it could be the whole body. And they sometimes have kind of lack of interest in food, a little bit of anorexia, sometimes even losing weight. It's quite rare, but they have also dark urine and pale stools. Jaundice is very rare. I've only seen it maybe 3 or 4 times in my career, and it almost always associated with the increase in bile acids is the other liver enzymes. It, of course, can coexist with other conditions. So that's where it becomes a complexity, and that's when you need maternal medicine specialists or obstetric physicians to help you navigate these cases where you are not sure if it's acute fatty liver, is it severe preeclampsia, or is it something else. Having history of hepatitis C makes patients a little bit more at risk, and I think that's why sometimes you see a little bit higher incidence among patients. And importantly, it recovers after delivery, as we said, about 2 to 8 weeks. There has been some cases where it actually went for over 6 months before it resolved. That's why you need to keep an eye on these patients. So I tend to bring my patients back to have a blood test 2 months after delivery, and then I see them with the result 2 weeks later. And most of the time it's back to normal. If it isn't, then I keep an eye on them. If by 4 or 5 months the liver enzymes are still high, then I tend to refer them to a GIT specialist to also keep an eye on them, just in case there is a pre-existing liver disease. So what investigations we need to do? And this is really very, very simple. So you need to do serum bile acids. Very important, has to be fasting serum bile acid. Just don't do the bile acids anytime, because sometimes physiologically the bile acids can go up, and you need to differentiate between the levels if you're monitoring a patient. So always do it fasting, first thing in the morning. I will come to the levels in a minute, because that's really where the changes have happened. You sometimes can see an increase in ALT and AST. Usually the gamma GT is normal. Don't worry about ALP, because alkaline phosphatase, as you know, is placental, it will go up. And you want to look at the vitamin K levels, mainly indirectly through doing a clotting screen, because very rarely, if it's severe, they can have a coagulopathy. Bilirubin may be slightly raised, but never to an extent for a patient to have jaundice. It is a diagnosis of exclusion. So in order to reach that, you need to do a lot of other investigations. You need to do an ultrasound to make sure there is no liver disease, there is no gallbladder disease. Liver biopsy is very rare, and I've never ever had to refer a patient for that. But look for other signs of preeclampsia. If there is any high blood pressure, any proteins in the urine, you may want to revise your diagnosis. A viral screen, A, B, C, as well as CMV and EBV should be done as standard, and autoantibodies for anti-smooth muscle and anti-mitochondrial. When you do all these tests and they all come back negative, then you can say it's obstetric cholestasis. You have to do these other investigations. Do not assume, because as you know, there is a lot of conditions that can give you elevated liver enzymes, and itching. And that includes hepatitis, acute fatty liver, which is a very serious disease, HELP syndrome, which is a very serious disease, drug hypertoxicity, very serious disease, severe hyperemesis, very serious disease. So you have to exclude the others before you make that diagnosis. Do not assume it's ICP until you've done that. And that's really, really important. If there is one thing you're going to get today from this lecture, is this exclusion is important. So what are the risks? PPH, extremely rare, but the issue is about vitamin K, and that's why we'd recommend the patients to have vitamin K. It is, there is also a fat-soluble vitamin malabsorption, and that's why when we give vitamin K, you need to give them the water-soluble one, because they cannot assimilate the metabolized fat. So you need to give them water-soluble vitamin K. Psychological distress is not easy to be having a big tummy, can't sleep at night with a lot of itching. And as I've said, it's important to make sure that postpartum reassure the patients because they would like to know. The main issue is that the baby. So all the symptoms obviously are not usually dangerous to the mother, but there is a big association with severe ICP and intrauterine death or stillbirth. And that's why you need to look for signs. Preterm birth is also associated with that, but I also feel that possibly that's a good thing because it's almost nature trying to save the baby by letting the mother go into labor. And the stillbirth is mainly a risk if the bile acids are above 100. So how we stratify? So I would like to refer you to the most recent RCOG guideline, 2022, the SFMFM Consult Series, number 53 in 2020, and we've classified them into 3 categories. Mild is below 40, because we said above 10 or above 12, depending on your lab, is high, but that's considered mild. You wouldn't worry about it. Moderate, 40 to 99. And then severe, more than 100. So the stillbirth association risk is when it's above 100. The management principles, it has to be multidisciplinary. So you need to get your neonatologist with you. You need to speak to the hepatologist. You need to monitor the patients on a weekly basis with both bile acids and liver function tests. And let's remind ourselves, it has to be fasting bile acids. You want to give symptomatic emollients to help with the pruritus, and then vitamin K supplementation, water-soluble, as we said, and advise them to have a low-fat diet, and weekly biochemistry. So what medications do we use? Emollients, I like this aqueous cream with 1% menthol, and I tell my patients to put it in the fridge. It's very nice and cooling. It can make it dry, and that's why you need to use oilatum as well, because that will make the skin soft. Antihistamines are safe to take. The chlorperamine and the promethazine are very safe, and they're very good. Now, the drug that everybody talks about is ursodeoxycholic acid, which has been shown to reduce the level of the bile acids. And what I have seen, even in the UK, is that sometimes people do not give the right dose. You need to go strong. You have to go up to 2 grams a day. Don't wishy-washy, give a bit 250 here, 500 there. So I normally start with 500 milligrams twice a day. And if they're not better after 72 hours, I go for 1 gram twice a day. End of story. Don't waste your time with 250s. Just go straight for it, and it's a very, very safe drug. It's not licensed for this purpose, but it does help with reducing the levels, and it does help with the itching. Dexamethasone was discovered actually in a trial. Coincidentally, it brought the levels down. It's not something that we tend to use. The same, again, we don't tend to use because although it brings the level down, it hasn't been shown to be that effective in improving the outcomes. An interesting drug is rifampicin. I use rifampicin quite a lot for patients who are refractory to UCDA. And I give 150 milligrams once a day, and that will be your second-line drug, which we normally tend to use. And it works most of the time. Again, it's very safe. And then consider metformin, and I will tell you why metformin may have a role, in particular in those patients who have ICP as well as gestational diabetes. Now, UCDA, so this paper that came out from Lucy Chappell and Catherine Williamson back in 2019 created a big controversy, because what they have found that it did not reduce preterm birth, it did not reduce stillbirth at all. Although it improved the biochemistry, it reduced the bile acids, it did not improve pregnancy outcome. So the conclusion was that it is mainly symptomatic relief. And sometimes it maybe reassure us as clinicians looking after these patients, because when you see the levels are down, but the UCDA, and it's really important that you counsel your patients accordingly, it is not curative, it's symptomatic relief. It is as good as having an antihistamine, that's all. At the moment, we don't have any evidence, it improves outcome. Now, I want to tell you about this story that's one of my patients. So we had this woman who's 27-year-old, had 4 previous pregnancies, history of recurrent intrahepatic cholestasis, and in her first pregnancy, it started at 29 weeks. We managed to deliver her at 37 weeks. She did not need medications. In the second pregnancy, it started at 26 weeks, and this time needed UDCA. And in the third pregnancy, it started at 15 weeks. And eventually, we managed to deliver her at 37 weeks. And then on the fourth pregnancy, it started at 21 weeks. And this time, she required UDCA as well as rifampicin. And we delivered her at 35 weeks because the levels were very, very high. In her fifth pregnancy, she came back. And this is what happened. If you look at the red line, something happened around that gestation where everything dropped back to normal. Didn't make sense at all. This woman has had 4 previous pregnancies, all with severe cholestasis, but this time the levels went down. And I remember I was trying to understand why, what happened. But then my registrar at the time, and he said, the only thing, Prof. Shehata, I can think of, that she developed gestational diabetes, and we gave her metformin. Could it be the metformin? And it's really interesting because we know there's a big link between gestational diabetes and obstetric cholestasis. And indeed, this is something we published. We call it the METRIC trial, and we have found actually that it's actually definitely shows evidence of reducing the bile acids through the FXR metabolism. And that's really interesting because since then, myself and Catherine Williamson, we've been trying to understand which patients respond to metformin. So not everyone responds to metformin, but we have had patients who respond dramatically to metformin. So what do you do? Fetal surveillance is important, we think, because we don't know why the baby dies. The assumption here that maybe the increased bile acids will cause a heart attack on the baby, and that's what the baby dies. That's from animal trials. But we know from the UDCA kind of effect that it did not reduce the stillbirth, despite the fact that we've reduced the bile acids. So that's actually not exactly true. So what we tend to do is we ask the patients to have weekly CTGs. The reality is this is just to reassure the patient, reassure us, because you can have the CTG now and the baby dies an hour later. Ultrasound for growth and LICA. Why? There is no evidence on any effect on the baby's growth. And if you are a really good sonographer to see evidence of meconium in LICA, which is normally an end stage, then you're lucky to do that. So really, the plan is to time the delivery accordingly. And this is the latest Green Top guideline from 2022, supported by the SMFM and the ESL, the Europeans and the Americans. And this is what we normally advise. If it's less than 40, deliver between 38 to 39. If it's between 40 to 99, go for 37 weeks. If it's above 100, you deliver at 36 weeks. Have I delivered patients earlier? I have indeed. I've had patients with 600 and 800, sometimes 1,000 of bile acids with no evidence of benefit with treatment. And in these circumstances, we discuss with the neonatologist, and we have delivered selected cases between 34 and 35 weeks, but you need to have the right neonatal support and neonatal unit. And as you know, in the UK, we're blessed to have that kind of expertise around that. But this has to be a shared decision. But the current recommendation is any level above 100, you need to deliver by 36 weeks. If you're not sure, do consult with people like us or Catherine Williamson, and then we can help advise, because there are sometimes very difficult cases, and we discuss them among ourselves. Remember, it will resolve after 2 to 4 weeks, but recheck again after 6 weeks. Always advise the patients there's a 90% recurrence in subsequent pregnancy. Counsel avoiding oral contraceptive pills, especially those estrogen-containing, and also HRT should not be avoided in the future, because the amount of estrogen in HRT is very low. But some of these patients, it could be a sign of early hepatobiliary disease, and therefore you need to refer them to your liver specialist, especially on those patients with the levels continue to be persistently high. Children may have altered metabolic processes, profiles, and that's mainly in people with the genetics that lead to this. So that's something that Professor Catherine Williamson looking at, but at this stage it's early days. And the special scenarios we always need to remind ourselves are the IVF, which is kind of now becoming increased, the multiple pregnancies, and also those who have an early start of the ICP before 28 weeks. These are the ones you need to keep a very close eye on, and do not manage these cases on your own in the private sector. You need to have a multidisciplinary approach to those patients. So what are the next kind of things that we're going to see over the next few years? There is a lot of emerging research on the FXR research and TGR5 receptor modulation. And the idea here that this may give us an opportunity to have specific drugs, especially with the FXR, that will be targeting patients with obstetric cholestasis. Machine learning models for stillbirth predictions, because we don't really know yet why the baby dies. So we need to find if we can achieve that with artificial intelligence help and try to look for things we haven't seen before. There is ongoing multicentral trials that we are part of the UK ICP studies. There are lots of studies trying to link the premature birth and the clinical outcomes to the levels. These are the guidelines I would recommend you to read if you're interested. So the RCOG Green Top Guideline, the SMFM Consult Series 53, the European Hepatology Guidelines 2023, and the most recent one is the FIGO Liver Disease in Pregnancy Framework. These are really good sources for educating yourself about ICP. And they all emphasize the importance of stratification by bile acids and the timing of delivery. And that's really important. Do not make that decision on your own. You have to involve your neonatologist, because they're the ones who are going to be receiving the baby. There are lots of good recent reviews I would recommend you to read, which is the Jelski 2020. That's mainly talking about the genetics and the bile acid transport. Catherine Williamson and Ovadia 2021. This is about the precision and early intervention. And then our paper on metformin as an adjuvant therapy. The FIGO, as I've said, is really good, because also it looks at what you do in under-resourced countries and middle-income and low-income countries. And Catherine Williamson and her team of 2020 about the geographical variation. So what are the key takeaways today? ICP is pruritus and elevated bile acids, full stop. Remind yourselves that it resolves after delivery. Important to exclude other liver diseases, please. So you need to do ultrasound, you need to look for blood pressure, urine to exclude preeclampsia, and you need to do a viral screen and an antibody screen. Very, very simple. UDCA is safe, effective, but it does not reduce preterm birth, and it does not reduce stillbirth. So it's mainly symptomatic. Metformin could be used in particular in patients with GDM, and also please consider rifampicin and use that safely. The fetal risks increase when it's above 100. If it's above 100, pick up the phone and speak to your liver colleagues, speak to your maternal medicine colleagues. Do not look after these patients on your own in your private clinic, because if you end up with intrauterine death, you are in trouble. Planned delivery between 36 and 39 weeks, depending on the stratification, as we said. And I really, really cannot underestimate the multidisciplinary approach is really key. These cases are very tricky and not always as straightforward as you see them in books. Thank you very much.
Thank you, Professor Shehata. Maybe we're lacking in time, so then we're not allowed to have a question. I know you will be bombarded with questions if we open the floor, and we received the notice that we could not. But if you allow me, Hassan, just a tiny thing. Would you consider your plan of delivery according to the baseline value of the bile acid? Or if you're treating your patient, do you have lower values, would that affect your decision? As far as we've said, the disease itself is not really cured by the urodeoxycholic acid. So if you have lower values under treatment, which value would you consider in planning your delivery?
Very good question, Amir. So as we said that RCOG acid can bring the levels down. So what is really important, if you had a test that was 100 or above at any stage, that's your cutoff. So even if it went down to normal range, that patient had 100 at some stage, because you could have brought the level down. But remember, what did we say? That UDCA does not reduce stillbirth. So yes, I will still deliver if the level of 100 was at 32 weeks, and at 34 weeks, the level is 40, I will still deliver at 36 weeks, because the starting point was 100.
Thanks, Hassan, for choosing a very nice title for your lecture. Obstetric cholestasis, what is new? I remember I presented in 1999 that when I first came back from England, we gave a lecture on obstetric cholestasis. I think Dr. Mazen was there. And when I see your lecture, my lecture was very basic. I think there's a lot that have, improved in the management, but also the awareness, I think.
Yes.
I think we are more aware of it, and general obstetrician are more aware of it.
I think, if I look at it, I think the three important things that we've learned over the last decade or two is mainly the stratification of the level. The point that Amir made maybe didn't come across in my lecture very well.
Stratification is new, yeah.
Yeah, is that it's important at any level. If you have 100 plus, you need to think about delivering early. And number three, that UDCA does not cure, it's only symptomatic. And that's obviously the most recent one. And then, of course, the development of drugs like rifampicin, metformin, and other drugs are really quite important additions. I think the next few years is going to be very exciting, because what Catherine Williamson and her team and the other teams in America are trying to find out is that which patients, according to their genetics, will respond to which drugs. I think eventually, I think this is where medicine is going to be, that who will benefit from what when it comes to these things. We don't really know in a lot of diseases who responds to what medications. It's almost always like luck of a draw. You try this one, you add that one, etc. Sure. So I think the genetics hopefully will help us with that.
Being an IVF specialist, Hassan, you said that it increases the incidence, but that is the late onset. But I think the early onset, we had a case of 6 weeks pregnancy presenting with full-blown intrahepatic cholestasis, and I think it was due to ovarian hyperstimulation syndrome. Yeah. So I think it's IVF with ovarian hyperstimulation will give you an early onset, whereas IVF in general will give you later onset. Do you agree?
Yes, but also I have seen a lot of patients with IVF with early onset without hyperstimulation.
Okay.
Yeah, yeah. So IVF, I think it's definitely an issue.
Okay. Can I أمون على الدكتور عامر في? I think Dr. Omar Tas and Dr. Osama want to ask 2 short questions. Okay. Omar, just 1 question. Is that okay?
But Dr. Hassan, about the liver biopsy, It's practical to do for every lady with suspicious
No,
of
no,
cholestasis.
I said no liver biopsy. I said I've never
No,
done
it's
it.
ultrasound and biochemical
Yeah,
markers.
yeah. Never, ever. I think these are very selected cases that you are suspecting something sinister that you need to do that.
No, no, my question was asked already by Dr. Amir. Thank you very
Thank
much.
you. Thank you very much.
Thank you very much, Hassan. It's my honor now to introduce our next speaker, Professor, I'm sorry, Professor Paul Fogarty. Paul is heavily involved with the FIGO. He recently accomplished the FIGO 2025 Congress as the chairman. He served as a consultant between 1993 and 2017 in Belfast with a special interest in labor ward management, ultrasound, urogyny, and medical education and leadership. He served on the RCOG Council between 2010 and 2016, first as an honorary treasurer and then as a vice president for global health. During that time, he visited Jordan and we were happy to see him. His lecture today is about preterm labor. Can we do better? So the floor is all yours, Paul.
Assalamu alaikum. Thank you. It is wonderful to be back here, and thank you to the organizing committee for the very kind invitation. And I have to embarrass Khaldun because I do remember very well the hospitality here, and the food was extraordinary. I didn't attempt this trick myself, but it did work out very well. I'm following Hassan, my good friend, with evidence-based medicine because there's an awful lot of problems around preterm labor. So I hope over the next 20 minutes, I've got 19 minutes, 52 seconds, to just tell you what to do and what not to do. That's all, because I see some very young colleagues here, and particularly diagnosis and treatment. Anyone can diagnose labor, I hope, but it's the prediction and the prevention. And I'm not even going to talk about delivery because that's another talk. We can do that maybe next year. So NICE has produced a very nice document. You think, great, that's where all the evidence will be. And you think this is fantastic. But whenever you dig into it, there is just 1.5, 1.5 pages on the prevention. I mean, that's appalling, isn't it? And it just maybe is the reason why we're so bad at it. And actually, the remainder of the whole guideline is on diagnosis and the treatment. And we're not actually very good at treating it either. The problem that I see with preterm labor is patients, and we feel obliged to do something. That's what we feel, and we have to do something, because if we don't. And we're trying to get this delicate balance of treating the right people and not treating people unnecessarily. A couple of statistics just to try and put it in perspective. So on the left there, you see more than 50% of women who deliver preterm have no identifiable factors, and approximately 2/3 of women with traditional risk factors go on to deliver term. You all know them. They've been in with threatened preterm labor, and you're inducing them with term plus 7. Really difficult. Same then when you look at the diagnosing this in a population. 70% of women will give birth at term, but more than 95% of women with symptoms, yeah, they're fine. So I went back, I'm going to focus on just the current screening methods. And I've actually had to take out fibronectin. I don't think fibronectin is used here. It's not used anymore in the UK. The company that produced Hologic have stopped producing it, which is probably a good thing, because although it was helpful, it didn't add an awful lot whenever we... So I'm first of all going to look at the clinical risks and look at cervical length, which is, I hope, the focus of my talk. So let's look at risk factors, and it's very interesting. We can categorize people into high risk, low risk, medium risk. And when you start looking at them, any undergraduate can give you these. In fact, it becomes, I always say, this becomes an obstetric textbook, the risk factors for preterm. I'll let you read these. Everything is a risk factor for preterm labor. You then look at fixed risks and interventions which are suitable, which are available. And it's barely readable because there are so many risk factors. And I've put I'm doing a talk later on this afternoon on artificial intelligence, and saying, well, maybe the future is that artificial intelligence can somehow tell us which one, and stratify these properly. But so far, systematic reviews have concluded that there is no effective risk scoring system. Okay, so we can do all these histories, our midwives can take all this and highlight it in yellow saying high risk, high risk. It doesn't work. So when it comes to prediction of preterm labor, you can look at the history, gynecological history, OB history, and fill in those, and it becomes a full trimester. It just becomes a full textbook again. And that is the problem, which we don't have a good way of predicting who's at risk, except if they've delivered before, obviously. But you know, the uterine abnormalities you may know about, obviously we don't. Premature rupture membranes, obviously that speaks for itself. And then the medical diseases and cholecystitis, we just heard as well. We get lots of iatrogenic deliveries there. So the current screening methods say, the one that a lot of us are looking at is, can we look at the cervix? And I did a lot of ultrasound in my life. I scanned, I still remember the day we first got a transvaginal scan machine probe, and we thought, wow, this is going to be amazing. And Tom is still here. I enjoyed Tom's talk. It's lovely photographs and slides and videos of the diagnosis. Now, we take transvaginal ultrasound for granted, but cervical length is still a problem. The issue with cervical length is, and the trials have looked at, do we do a single measurement? When do we do it? How do we do it? Do we repeat it? Is it an absolute figure? Is it the change or the speed of change? It's the same as looking at babies who are growth retarded. You know, how do you diagnose those? So there is some very good papers on this. This is a Cochrane review. It's been repeated twice. Currently, there is no evidence, I repeat, no evidence for routine scanning. So if you're scanning cervixes, trying to diagnose, please stop. All you will do is frighten yourself and frighten your patients, okay? I still remember a woman coming to my clinic from New York, and she was terrified even to get on the plane. Her gynecologist there had said, oh, your cervix is 1.5 centimeters. I had nearly had a failed induction with her at term plus 10 because we couldn't induce her. Her cervix was fine. And you remember those. So cervical length evaluation, again, this is an up-to-date review, and I say, it's just the evidence is very clear. No evidence for routine scanning. And I know some of you do it, particularly in private practice. It's tempting to do it because you have the scan machine there. Please, no evidence. So my summary slide for cervical length, no routine scanning, but there is a place for it if there's a previous preterm birth. The suggestion is scan around 14 weeks and look at the length, okay? And then you can repeat it, as you'll see there. And if it becomes short in someone who's at a preterm birth, then there is a role for cervical cerclage, and that will be the next phase of my talk. If you are going to do a scan, and I know some of you will want to continue doing scans, don't do it too early. Maybe 24 weeks, that maybe seem, when you're approaching viability, that might be a reasonable time to do it, okay? If it's short, vaginal progesterone, I'm going to come on to that, and normal care if it's long. Don't repeat the scan. Some interesting work going forward. I didn't see any Samsung machines out here, but some of the machines may have it. Samsung are looking now at, I have no conflict of interest with Samsung, I have nothing to do with them except I love their technology. They are looking at consistency of the cervix, okay? And they can now automate this, still being tested and trialed, but that will be very interesting if it's quality, not quantity of your cervix that is important, okay? Watch that space. But what I want to focus on as well is we're all busy clinicians, and I am a busy clinician, or I was, and that's what I like. The real world is very different, and Tom referred to real world ultrasound. Clinics are busy. We've many distractions. We're running around and trying to then sort this out. And the one thing I'd say, particularly if you're in large teaching hospitals, is set up a preterm birth clinic to do this, where you have time to look at these patients, okay, particularly the ones with a previous birth, preterm birth, okay? Just take them out in the same way you would take out preeclamptics or diabetics. You would look after them separately. And there are then those various tools we can look at. Ultrasound, fibronectin's now been stopped. Looking at surgical treatment, progesterone, and the continuity of care, getting to know your patient, getting to know you is very, very important. Some nice work going on in London with the Quip app, which again, unfortunately, it's building in current examination, and it's also looking at risk factors. It is useful because, a bit like we heard earlier, you can then tell a patient, well, actually, we've put in all your data, and your risk of a preterm birth is less than 1% or less than 0.1%. And that's very, very helpful. And it's a free app as well if you want to try. So if we know someone's at risk, can we prevent it? The current tools we have are, I'm going to talk about quickly, 10 minutes. Progesterone, cerclage, and antibiotics. So where are we with progesterone? Jane Norman, very good friend of the college, very good friend of many of us here, has a fantastic article, and I've just summarized this here. And she basically said, yeah, it demonstrates efficiency. There's also no data on long-term effects, and it really doesn't show an awful lot of benefit beyond the neonatal period, but actually that's probably all that we as obstetricians are interested in. The problem is that the limitation of progesterone therapy is that it's applicable to only a very small number of people, and it doesn't work on a population base. So my take-home message for progesterone is consider it in the high-risk people, the very high risk. That's people who've had a spontaneous birth or a loss and with a short cervix, okay? It's very easy. Don't be giving progesterone routinely to everybody, okay? And if you are going to use it, RCOG has now said, FIGO said it has to be vaginal progesterone. We're not the injectable hydroxyprogesterone, okay? Happy to take questions on that. Cervical cerclage is something we all did. In fact, as registrars and SHOs, we were doing it, and I'm actually appalled at how bad our technique is. And there's some really nice work going on about, and we had a nice workshop at FIGO on how to put in a suture. Everyone thinks they can do it, but actually most of us do it very badly, because there's lots of different ways to do it. So when do you do cervical cerclage? You can do it in A when it's ultrasound indicated, to say when you do a scan and the cervix is short, but that's in somebody only who's had a preterm birth. Multiple second trimester losses, this is where it's a history indicated. And the last one there is where the cervix feels dilated. That seems a bit, and that's not what I'm calling a rescue or an emergency clearance. That's just where you do digital examination and you feel you can get a finger in, which you will get in a Paris patient anyway. So some nice work looking at cerclage for sonographically short cervixes, and I've summarized it in the purple box there. In singleton gestations without prior preterm birth with a short cervix, it does not seem to prevent. So just because it's back to my patient from New York, just because you have a short cervix, if you know other preterm birth, don't put a stitch in. And that's transvaginal cerclage, a nice up-to-date, it says exactly the same. So the current evidence doesn't support routine use of pessaries either, because that came along. We thought this would be a little bit more patient-friendly, a little bit less intrusive, but no evidence that these pessaries work. I mentioned rescue cerclage. We've all tried it. I actually put my hand up. I'm not very good at it. The membrane's ruptured all the time. I don't know how we're getting good results on that. So I suspect there needs to be a serious bit of work done on the technique, what sutures to use, whether you use tocolytics. But this is from the RCOG guideline number 75, and it is saying that there is some evidence from randomized controlled trials. But I think doing one yourself every year is not good enough. I think we need to get standardized techniques and standardized experts who can do this. But in my hands, I was very disappointed. The problem is we tend to do it because we think, well, we've nothing to lose. Not good enough, I don't think. Going to finish just with a couple of minutes on antibiotics. It seems very tempting. Well, let's give the patient, if she's, you've done a vaginal swab and there's an infection, or which is asymptomatic, etc. The summary here is the logic seems to make sense, but cause and causation aren't the same, are they? Cause and association. Asymptomatic bacteriuria, we used to think, as a medical student, there's no increase. We used to think this was a risk for preterm birth, but actually empiric use of antibiotics doesn't seem to work, okay? We had a nice talk at dinner tonight. Some of you are on the RCOG genomics committee, because there is a breakthrough coming, and this is again, just looking through my crystal ball, is that there is some genetic associations. and it makes sense. So I did a little plug here for the genomics at RCOG, where those of you who are interested and want to educate yourselves in the omics can go to the College Hub on genomics. So I'm going to stop shortly. My take-home messages on preterm, I have 2 slides just on the take-home messages of preterm birth. One size doesn't fit everybody who's had a preterm birth, okay? One size approach means everyone gets the wrong treatment. This slide, if you're high risk, previous preterm birth, use progesterone. Use vaginal progesterone for short cervix, yes. Do not do cervical length screening for low risk patients, doesn't work. Cervical length screening, yes, for high risk patients. And cervical cerclage, as I say, it depends. It really depends. If it's just a short and a low risk patient, probably not. But if they have preterm risk factors or preterm birth, yes. Please consider using a preterm birth clinic for your own protection and your own sanity and for your patient's benefits. High vaginal swabs screening doesn't work either. Prophylactic antibiotics doesn't work. Tocolytics only to use to give you that 48 hours for steroids. Do not be putting people on tocolytics. I didn't have time to go into that whole the data behind that, but tocolytics given here, take a few terbutaline tablets or whatever, it doesn't work. And so we've learned the lessons the hard way with intravenous tocolytic therapies. So get it on board just to allow transfer to your neonatal unit and for your steroids. So thank you very much, ladies and gentlemen, for your attention. I'm happy to take any questions.
Thank you, Paul. Thanks, Paul, for excellent presentation, and thanks for the extra time. We're running into a prayer time. But before our last lecture, I would like to open the floor maybe for a couple of questions. Okay, Doctora, any other before we end? Dr. Umayya here. So.
Thank you so much for your beautiful lecture. And I like the arrangement of the slides also. I want to ask about ladies with stage 3 and more uterine prolapse. Is there any advice for risk of preterm labor and the management for them? Thank you.
That's very interesting, bringing us right back to our earlier talks this morning. Prolapse, and as someone who was a generalist and obstetrician one day and a gynecologist next, I can't see any link between prolapse and preterm birth, unless you're going to surprise me with some paper that I haven't seen yet. No, I don't think so.
Can I just ask you about the role of antibiotics? Because
Yes.
there are some studies in this US now, they're going back to the cycle of giving antibiotics in preterm labor and being very aggressive and even doing an amniocentesis and looking for any evidence of sludge and infections and things like that. So I would like to hear your views on that. Thank you.
It sounds very American, that's all I'll say. And yes, I do believe in evidence-based medicine, and I did a lot of amniocentesis over the years, and there's sludge and cloudy liquor in lots of people, but it's, Tom will tell us that's normal. You see all sorts of funny liquor. Back down to let's giving antibiotics isn't harmless, and we're having this huge debate with Group B strep at present, which is a wholly different argument. But I certainly wouldn't recommend amniocentesis. I think if you've a symptomatic patient and you do a swab, you treat it, but I don't think you use it for the treatment of preterm birth. Because Roberto Romero, our good friend, has very clearly outlined that there are multiple reasons why people deliver early, and infection is only one of them, lots of other reasons.
Question, please.
Thank you, Doctor, for your nice lecture. I want to ask about in 2023, Professor Nicolaides talk about the cervical length that is indicated for cerclage, that is below 1 centimeter. It's more neonatal outcome than 2.5. The cervical length, if you do cerclage below 1 centimeter, the neonatal outcome is more than, or benefit more than 2.5 centimeter. Cerclage indicated ultrasound.
So I'm not sure exactly what your question is. So if the cervix is,
If
if the
cervix
cutoff is 1 centimeter?
Yes, if the cervix is below cervical length, below 1 centimeter, 1 centimeter cervical length, the neonatal outcome to do cerclage is more, the benefit, more than 2.5.
It probably is, but 2.5 has been the sort of standard cutoff. But I come back to the question about doing the cerclage. You know, where do you do it? How do you do it? What suture material to use it? You know, we really are. We're still exploring exactly, but there is, you know, there is myths about cervical cerclage. So I have to be. I'd love to. Maybe we'll talk about that over lunch or after prayers. Yeah. Okay.
Thanks, Paul, for the lecture. And Paul, can you please send that picture for me? My son in the picture is now a 5th-year medical student, so it must have been quite long.
The food was good then.
Yeah, thank you.
Okay, thank you.
Okay.
Dr. Falah.
Just an observation. With IVF and multiple pregnancy, I noticed that most of our colleagues, they go, even without a history indicating doing cerclage, they go and do cerclage. What do you think of it? It's very important.
I think that's appalling, and I think, you know, there is very little evidence that, there's no evidence that cervical cerclage in twin pregnancy is useful. It's probably going to do harm.
Thank you. And probably our colleagues who is asking about 1 centimeter and 2 centimeters. Probably 1 centimeter is indicated to put a cerclage, and 2.5 centimeters is not indicated to put a cerclage.
Okay. Well, it's again different. But twin pregnancy is a full another discussion, and again, the vaginal progesterone is perhaps useful rather than cerclage.
Thank you, Professor Paul. Our next speaker before lunch and prayer is Professor Yasser Abu Tayyib. We'll talk about aesthetic gynecology, a misleading science, debated surgery. Professor Yasser is a chair Egyptian representative committee of the RCOG. Professor Abu Talib, yes. Yeah, what did I say? Tayyib. It's all, yeah, you're Tayyib, I believe. You should be Tayyib. So, sorry for that, Professor Abu Tayyib. He's a professor of obstetrics and gynecology at Shams University, Professor Army College of Medicine, certified trainer in UNFPA, WHO, and USAID, fellow of the Royal College of Obstetricians and Gynecologists, and examiner at the Royal College of Obstetricians and Gynecologists. The floor is yours. Thank you.
Okay, thank you very much. So just to start with, I would like to thank again our team and your team as well, leaders of this Congress. Dr. Abir, thank you very much. Dr. Medin, thank you very much. And my dear friend, Dr. Mehed, thank you very much. To be honest, over the last 2 days, I put about 2 kilos or something like that. Food's unbelievable. I cannot stop eating and eating and eating. And ask my friend Muhammad, just take me to my room just because I'm about to sleep. Thank you very much for that. No, الأكل بتاعكم أحلى من الكشري بكتير، مش هكذب على حضرتك يعني. Okay, so after the wonderful scientific part that we have, that we went through, Hassan, my dear friend, we will miss you very much. You are great. And as well, Paul. Where is Paul? Okay. Thank you very much for your wonderful presentation, scientific. But let me discuss another issue, which is completely different. I was the one who invent the idea of what's called aesthetic gynecology. I know Hassan is going to kill me after finishing this presentation because, and thanks God, Kate is not here. Thanks God. Please don't tell her, Hassan, because this is against the rule of the Royal College. They hate so much aesthetic gynecology. But let me just dig through, just to explain that there is a misunderstanding of what's aesthetic gynecology. So let's have an agreement that beauty is deeply rooted in the mind and the soul of everyone. No difference between different colors, different shapes, body mass index, age, and something like that. And Hassan will ask me, do you have proof for that? I will tell him, definitely. These are Miss World. Dark black color, African, Indian, and European, with all of them are the leads of pretty all over the world. No difference between the shape and the color as well. And if you ask yourself, do we have certain things that design your capability to say that this pretty or not? I will tell you exactly. We have three components. Complexion, which means smooth. Symmetry means symmetrical, and use means no wrinkle. So if you divide the body into two halves, and you have the right side is the same, right, like the left side, both of them are stretched, smooth, and no wrinkle. This is the guideline of pretty. Am I right? Definitely I'm right because of the history. Let's go to the history, and we have a very nice history. Let's go for the first 4,000 before curse. They were the first one to use makeup, even for the king, just to make the right side the same like the left side. They were the first persons. 3,000 years later, Greek invent or create a god of pretty. Do you think that this lady is pretty? I don't think so. But anyway, the rule of pretty, if you divide that into two halves, both of them will be complexion, symmetry, and use. This feeling was changed completely with the 3rd century, back in Alexandria, where Flaminius of Alexander was the first one to apply this rule to the genitalia of women. His friends start to complain against their wives. They have disfigured vulva and vagina. Then he was a great doctor. He decided just to help them by modify and reshape and return the vulva and the vagina to normal shape to enjoy his friends. This was transferred actually by Monsieur to Europe in the 6th century. And as you know, Monsieur was the first one to put a book in gynecology where he wrote the rule of cosmetic reasons, excision of the vagina and vulva. 2 decades later, Tortella was the first one to create and to use catgut. So they start to cut the genitalia and suture it using catgut. However, during the 18th century, something happened which changed everything. A lady with prosthesia, she fed up of what's happening. She grabbed her womb and cut it. She bled to death, but this attracted the attention of gynecologists that you might cut the genitalia and suture it to control bleeding. Since then, the vaginal surgery started to spread all over the world. However, and 20th century, in the year 2009, Bramwell and Brado were the first one to attract the attention that people wake up. Many ladies started to ask for operation for the vagina and vulva to modify their shape. And they called these operations cosmetic female genital cosmetic surgery. These operations, no indication and might have a complication and no experience as well. That's why in New Zealand, they send the questionnaire for GB and the gynecologist asking about what's the cosmetic surgery. The Royal College started to revise the notes of the ladies between the year 2001 up to 13, over 13 years, and the American College of Gynecology revised the notes and they decided to have a committee to study the causes and make serious recommendations. What are these recommendations? Did they prevent aesthetic gynecology? No, they said that genital examination is very important, and you have to tell everyone that there is a difference between a lady and the girl and the girl regarding to the size and the shape of the genitalia. However, they put a cutoff age of 16, never ever to touch the genitalia of a girl less than 16. If she is insisted, refer her to a psychiatry to discuss the situation with her and use as well just local medication to improve that. However, they add that anyone interested in doing that operative intervention, he must have special training for that. And they provided just a note that it's completely forbidden to use energy producing because it might cause some of burns from down below, especially laser. So what's aesthetic gynecology? Aesthetic doesn't mean beauty. Aesthetic means perception of what you see. It's big, it's small, it's pretty. In relation to what? In relation to the standard anatomy that was published in the American Journal of Obs and Gynae in the year 2017 with standard measurement of the vulva and vagina. So if you have something like that, abnormality of the genitalia externally, what are you going to do? You are going to do what's called plastic surgery. What does it mean, plastic surgery? Plastic surgery, it means reshape. Reshape for what? To return to normal anatomy, which will serve normal physiology. So what you do is just to return. ربنا سبحانه وتعالى خلق البني آدم في أحلى تقويم. So what you are going to do is just to do some operative intervention to return to normal thing. This is completely different. People, please, please. This is completely different from what's called cosmetic surgery, where you have a very nice picture from down below. And the lady come to ask me to become more pretty. How? Put me ring. Put me tattoo. Sound very strange. So you are looking nice. No, no, no. I would like just to have a surprise to my partner. How it comes, I don't know. So there is a misconception of what we are doing as gynecologists. We are doing plastic procedures, which is aesthetic. Aesthetic means perception. It's abnormal, prolapse, abnormal. Stress incontinence, abnormal. Vaginal prolapse, it's abnormal. Vulval abnormality, the same, and vaginal abnormality at the same. This is completely different from cosmetic, which is the dermatologist and plastic surgery. So if we have abnormal anatomy, which is associated with this complication, recurrent inflammation, superficial dyspareunia, irritation, itching, pain, and affecting the social life. Her husband is, and she is, okay? And we would like it just after doing our best from conservative management and use hyaluronic gel, blah, 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 blah. So we have to do something, not to leave her. Why? Because because if you restore normal anatomy, you will have normal physiology. This is the main thing. So you will restore desire, sexuality, continence, fertility, and genital bleed. At that time, the lady will be self-esteemed. This is the anatomy. I'm not going to, this is the layer, okay? Superficial, the nerve, pudendal nerve, and the muscle, superficial and the deep muscle. What are the procedures that we can do as plastic, not cosmetic? It might be surgical or non-surgical. Let's go for surgical. It might be vulval or vaginal. What's about the vulval one? We are not excising anything. What we do is just slanting the stratified squamous epithelium keratinized part, and that's it, keeping the intima intact, which is highly vascular, so no fibrosis, to restore the normal shape. Meanwhile, in vaginal cases, we have to excise. Why? Because connective tissue is completely destroyed. So we have to remove this destroyed connective tissue with the tissue and reconnect the healthy one. So this is different, like in cases of classical rebirth. You know, I'm professional in pelvic floor surgery, and we used to have regular courses for urogynecology, me and Mohammed Abdel Fattah back in England, back in Egypt, every 6 months for 3 days, doing about 30 to 40 cases and hands-on. What's good news that these procedures will be outpatient procedures and not costly at all. You need just a table and 2 chairs, one with local anesthesia, xylocaine 2%, with a special type of cream, local anesthesia cream, and start needling and inject the local anesthesia subdermal, and what you want only for an instrument. Okay, not bridge one, because it's expensive any time. It's, as you see here, small scissor, knife, non-toothed, and needle holder. The non-surgical procedures are all of that, but laser, don't use. This is according to the guideline, but you can use whatever, and PRB, to be honest, it's good in repair. Doesn't mean that everything is all right. You have to have a consent. Why? Because there is no definite confidence or definite evidence that this operative intervention will be successful. So swelling is the commonest and might persist for about 6 months. Disorder of wound healing because of scratching. That's why we give antihistaminics, asymmetry, and dimple and over and under correction. However, pain, post-aortic bleeding, hematomas, scars, unlikely to occur. Disorder of sexual sensation and infection, very rare because it's highly vascular. Let's go to the literature, and the complication is less than 1%. Meanwhile, other procedures in the vagina, prolapse, incontinence, cystic excision, absence vagina, tight vagina, we are doing all of that, and we have definite evidence. But the vulva and some part of vagina are not that. Do we have evidence? Yes. Some evidence, this is the British school, have some sort of evidence, but still, we are need to more and more and more, just to have a conclusion, but still not there. And what about the FDA? In the year 2019, they started to approve the operative intervention, and they put that chart and said that if you are going to do this operation, the purpose of this operation will be, and the complication might occur to that. And whoever want to do it, just to do, but the surgeon must tell you that he's expert in doing that. American school said that practicing cosmetic surgery, which is now aesthetic gynecology because the name has changed between cosmetic surgery and aesthetic gynecology, within American College of Gynecology recommendation is desirable. Ladies and gentlemen, let me just to finish my presentation as we are just one unity, Arab, okay? Either Christian or Muslims. So I tried to gather information regarding to the opinion of the Christianity and the opinion of Islam as well. And Catholic and Orthodox found that they would prefer never ever to touch yourself because this is the God invention. However, they are not denying doing this operative intervention if it's needed. So Christianity accept this operation. What about Muslims? If it's allowed to me to speak in Arabic in this case. So أحكام الجراحة الطبية والآثار المترتبة عليها صفحة 193 للدكتور محمد المختار الشنقيطي. عمليات تجميل الأعضاء التناسلية ليست كلها محرمة ولكن فيها تفاصيل. فإذا كانت هذه العملية لإزالة عيب خلقي، زوائد تعوق العضو عن القيام بوظيفته، إزالة عائق، إزالة تشوه، أو توجع حاجة طبية، فكل هذا مقبول. هل ده مقبول من عندنا؟ لا، ده مقبول بناء على حديث لرسول الله قال جاء إعرابي إلى رسول الله صلى الله عليه وسلم فقال يا رسول الله أي الناس خير؟ قال أحسنهم خلقا. ثم قال يا رسول الله أنا تداوى؟ قال تداووا فإن الله لم ينزل داء إلا أنزل له شفاء علمه من علمه وجهله من جهله. Is that all? No. لابن نجيم صفحة 91 الأشباه والنظائر للأسيوطي وجود هذا العيب أو الضرر موجب للترخيص بفعل الجراحة لأنه يعتبر حاجة فتنزل منزل الضرورة ويرخص بفعلها. أما إن كانت عملية ملهاش لازمة أو مش عاملة أي مشكلة فيو دونت نو. So, ladies and gentlemen, thank you very much to listen to me. This is my recommendation. Aesthetic gynecology, it's mainly plastic. Reshape. We don't do rings. We don't do tattoos. We don't do, no. Restoration of normal anatomy and physiology, mostly official procedure with low cost, a safety margin is there, highly satisfaction rate. Procedures need more assessment, best practice by gynecologists. It's part of our specialty. Thank you very much.
Thank you, Professor Yasser. One question, if anybody. Dr. Falah. Dr. Falah, one question, please.
Dr. Yasser,
Yes.
whether we call it aesthetic or cosmetic, I think it is probably trying to ameliorate the unnecessary procedures which has been done under the name of aesthetic gynecological practice. I think we have to go back. The WHO now is saying that all of what we say, the aesthetic surgery, is not legal. The WHO.
I'm sorry, it's
Even
not.
with
It's
yes,
not.
yes,
Excuse
yes.
me. By the
I
way,
think
I am a
that-
member of WHO group back in Egypt. I'm
The
representative.
Vigo, sorry, the
and-
Vigo.
And
Vigo.
by
So
the
we
way,
have to be very careful.
by the way, Mohammed Mumtaz is part of the
the
FIGO,
FIGO, sorry,
and
not-
I have been working with FIGO for a long time. It's not said that, but it's said that conservative management for operative intervention could be accepted except use of energy producing specially laser. This was produced 2020 and it's still there. But operative intervention, that's fine. By the way, cosmetic, that's what I said. It was initially cosmetic, which was changed actually in the year 2012 to aesthetic. And the aesthetic doesn't mean cosmetic. Aesthetic means two types of procedures, either plastic one or cosmetic one. So aesthetic means perception. So I see this girl, she's sweet. This is the perception, what I say. Then, so I would like just to wear that. This is cosmetic means forbidden completely. I agree with you completely. That's why rings, tattoo, and so on. But prolapse.
Yeah, that's a surgery.
Okay, the prolapse.
Procedure repair, that's surgery. Procedure repair is surgery. Complete perineal tear is surgery. Repair of
Yes, yes.
This is surgery.
This is plastic surgery.
And you cannot do it. And when you say that, I'll do it just with one person in a clinic and 4 instruments. This is not surgery.
By the way, sir, I said in my presentation we have two types of operative intervention. Valval procedure could be done out. Do you know fountain operation? You know.
Of course.
Can you do it in the outpatient clinic? Can you do it in the street?
Yes, remind me with the days when I used to be working in Egypt, where they used to deliver and do cesarean section in the clinics. This is not right. If we say this in our clinics, that will...
What do you do for cases with classical repair over tightened? Fenton operation. What's Fenton operation? Cut vertically and suture.
You have to
So
have
this is
you
could
have
be
to
done.
have a medical legal coverage.
Professor
If you do
Yasser.
it in your clinic alone, doesn't give you a medical legal coverage. If anything happened with you or with any one of us, it doesn't cover you medical legally. You might go, I might go to the court if I do it, or anyone might.
Sir,
go to
if you want to do it in your clinic, do it. If you don't want, I will do. Thank you very much. It's very easy.
Dr.
will
Ayub, Doctor, thank you for your conclusive.
Thank you very much.
Oh, by the way, it's not allowed in Jordan to have such a surgeries in the clinic side. And please be at 2 o'clock sharp here after prayer at Ashtar and lunch at floor 7. Thank you.